And so it ends by actually developing consolidation and damage to the lung itself, because it's the byproducts is caseous material itself. And so you get a lot of what happen as cavitation. You get consolidation and cavitation, and within the cavity itself, the caseous material, the pus itself, the products of the bacteria, the bacilli here, with the tissues, with all the secretions and all that creates the caseous material. And that's why we see a lot of more, and it's really a violent reaction itself. And so in adults, we see this only happening when the second time you get exposure. So the second time may not occur except when you're after your age of 10 years, 12 years. And so if you're going to see it in children, you're going to see it in adolescent or teenagers. But mostly you're going to see it in adults, especially young adults itself. So the other type of TB is there's cavitation there. And a lot of caseous material, therefore productive coughing itself. While in children, actually, it's like a simple pneumonia or no symptoms at all. So you don't have any actually cough, you don't have, or very mild cough, and a very simple pneumonia and all that. So that's why is the clinical picture, the pulmonary manifestations are different between adult and children itself. And so it's important. This is just a quick overview now. So now going back, so what do you have? You have either asymptomatic presentation, you might see that, symptomatic in which you have a simple pneumonia, like any other pneumonia. Nobody can know it except if you do a PPD skin test. And this is a typical pneumonia. Actually, you never know whether this is a bacterial or TB. It's a right upper lobe consolidation. It could be even bacterial itself. But this is how it can be confusing. But sometimes we know if you have either lack of resolution from the antibiotics, or if it occurs in patients who are coming from an area where there's a lot of TB, especially poor areas or places with overcrowding and all that. When you see that picture, then you worry about, could I be dealing with TB itself? The same thing, this is a consolidation in the lower part of the upper lobe. Now, in addition to those, the asymptomatic or the pneumonia picture, as I said, we already talked about the progressive primary pulmonary disease itself, in which actually the pneumonia actually spreads if the child is young or sick and the immunity is weak. You may get progression or spreading of that pneumonia itself, and you get a progressive type of pneumonia itself. This kind of pneumonia is the only, it's really actually uncommon, but it's the only pneumonia in children that actually may look like an adult type, because it's actually, they look sick. Most pneumonias in children, actually, they look reasonably well, at least with the TB itself. So progressive primary pulmonary disease is actually a severe pneumonia, which we see it in children itself. Now, in the regional lymph nodes itself, the higher lymph nodes, two things could happen. Could either it gets bigger, and compresses on the bronchus, and so what you end. If you have partial compression, you get air going in and coming out with difficulty, and so air trapping itself. So you get emphysema and you get wheezing. And actually, most of the time you get simple wheezing, and without only higher lymph nodes and no pneumonia, it's misdiagnosed sometimes as asthma. And that's why sometimes asthmatics, actually, if it goes on without lack of response to bronchodilators, you should think about TB, because TB can manifest itself like a patient who's wheezing. Or you can get actually complete obstruction from the big lymph node, and air is absorbed, so you get collapse. So if you see an emphysema or area of collapse which is persistent, you should think about TB also as a possibility. So these are the different scenarios that make you think about TB itself. Or you can actually get the lymph node breaking into a bronchus, and the caseous material inside the lymph node goes inside the bronchus and actually blocks one of the bronchi, and you get collapse too. So these are all clinical manifestation itself that you might see. So you might see with, as I said, asymptomatic, you might see a simple pneumonia. You might see actually severe pneumonia. You might see somebody with just higher lymph nodes. You might see somebody with collapse, or might see somebody with emphysema. All of these different forms Or you can see somebody with effusion. All of these pictures that you've seen, and these sort of present the broad spectrum of pulmonary disease in any child. So that's why always you have to have a high suspicion of TB. There's no specific way of knowing the difference. These don't look different from between a child with TB and all that. In adults, it might look different, but here in children, actually, they can look the same itself. So these are the different, if you have different forms, pulmonary forms of TB. It's not just one single type of pulmonary disease presentation in children. This is an effusion, I mean, complete obliteration of the lung on one side with obliteration of the renal angle. You cannot. Now, secondary TB, this is actually what we call secondary or reactivated TB, or actually the classical TB that you see in adults, where actually here you get cavitation, and when you have cavitation, then with a lot of cases material, then you cough it, and you have productive coughing itself. And also because of the cavitation, you may get destruction of blood vessels in the parenchyma of the lung, so you get hemoptysis. I mean, so you get hemoptysis in this type of this doesn't happen usually in children except in teenager or adolescent. And starting from 9, 10 years of age sometimes, okay, you get it, TB, primary TB at the age of maybe 2 or 3 years, and then a latent period, and then later on reactivation at the age of 9, 10, or 11 years itself. Or in adults afterwards. Now, systemic, in which actually, okay, either the bacilla can stay inside the lung or it can spread around the body. It can go inside the blood vessels and spreads throughout the body and goes to different organs itself and becomes like sepsis or bacteremia. But here we call it bacillemia or miliary TB itself. So miliary TB because, the reason miliary, because it actually goes, when it goes also back to the lung and causes sort of like small nodular, actually infiltrates itself, milia. That's why, so it looks like actually. لا مو شرط يكون يعني هو ممكن يكون primary. هو ممكن primary or secondary. Actually, it's more like a primary rather than second. Secondary بيسمى له اسم ثاني يعني. إيه لا secondary usually years. يعني secondary مثلا زي يعني زي ما قلت يعني secondary TB that we see in children يعني is actually, as I said, 9. يعني ممكن لك at the age of 1 or 2 or 3 years, and then latent period, and then reactivation at the age of 9, 10, 11 يعني years usually. Secondary يعني ما نشوف secondary TB حتى secondary اللي هي lung, we never see it يعني definitely not below 5 years of age. يعني. Well, depending, but usually tend to be smaller nodules. And here think about it actually like septic emboli going through the blood. يعني it's actually and then going back to the lungs. So it's actually very small nodules in a sense. Maybe if they stay for a while يعني in the lungs, they may create septic يعني gaseous material. So it's like bacteremia, I said, and it goes to the blood and goes to all the other organs. It goes to the lungs, it goes to the brain, it goes to the lymph nodes. So as if you get multi-organ involvement itself, because spreading through the blood. يعني TB usually spreads من lungs lymphatics يعني rather, but this actually gain access to the lungs itself, to the blood. Well, if you think about it, actually, it goes to the eyes rarely. Like if it goes there, produces بنسميها choroidal tubercles. برضه tubercles يعني هي tubercles ممكن تكون small, big, whatever. لكن يعني زي الكرات الصغيرة. And these are pathognomonic of TB itself, but it's uncommon. But if it's seen, that's why you can do a fundus examination or ask the people from ophthalmology to look at it, and they can tell you this. Oh, looks like TB. The other thing to tell you about, actually, I don't want to go into investigations yet, but generally speaking, because PPD skin test is one of modalities that we use for investigation, generally speaking, the milder the infection, the easier to get a positive skin test. The more severe infections, actually, severity of infection can actually suppress your PPD skin test itself, can give you a false negative itself. So miliary TB, that's why half the times that you test for PPD can be negative. It's not TB. It's just immune system is overwhelmed. هذا شيء ثاني لا negative. Yeah, allergic غالبا. يعني دي كان المفروض الميلاري TB لكن it doesn't show actually because they're so small. جايز في السكرين يبان اكتر لكن never actually shows في البروجكشن. Adenopathy, very simple. انه you get involved on the lymph nodes, like اللي يجي لهم كانسر مثلا بيجي لهم lymphadenopathy. برضه the same thing in TB, you get lymphadenopathy. It can be localized lymphadenopathy مثلا في the neck region or generalized lymphadenopathy. If it's in the neck, it comes in the differential of diagnosis. I just put مثلا these are the things that you might think about it. You differentiate from the acute adenitis itself, which you can do to staph or strep and tonsillitis and so forth, or it usually from the differentiate from the other chronic infections that can cause adenopathy, cat's disease, for example, itself. Always, يعني a problem is because the lymph nodes in TB, يعني acute ones are easy to pick up. لأنه lymph nodes are red and hot and so forth. Like in TB, the lymph nodes are not red and hot. Actually, they're sort of enlarged, but non-tender actually. So they more look like malignancies rather than actually than acute infection itself. But they differ from malignancies that actually here they're firm or matted, firm, while actually in malignancies they tend to be hard in consistency itself. That's one of the major features itself. So adenopathy, when you have somebody with like localized or the common is localized نشوفهم أو generalized lymphadenopathy, you should think about TB as a possibility. CNS disease, just very briefly أعرف إن هو you can have either meningitis وجايز لما ناخد أو تاخد meningitis جايز نذكرها في actually tutorial هناك how to differentiate TB meningitis from the other meningitis itself, but it can produce in the different two forms. Meningitis زي ما البكتيريا can cause meningitis or can produce brain abscess. فهنا ال TB can produce meningitis or can produce tuberculomas. Brain abscess due to TB, we call it tuberculoma because actually tuberculoma, it sounds like a malignancy, and that's it actually. It can produce, like, it can be a space of malignancy, it can be look like a tumor. And also because the inflammatory manifestation ما يكون فيه fever. يجي الهيستوري كذا مرة النيوروسيرجي دخلوا مريض no history of fever, nothing. Spatial crippling, they think it's a tumor. They go inside at the fresh frozen biopsy, they find that actually it is TB and not actually glioma or whatever like that. That's always can happen itself. So this is just to know that actually the different presentation can present as a brain abscess or tuberculoma. Other systems can involve the abdomen TB, can intestinal TB, musculoskeletal can get arthritis with it, especially the large joints. Vertebral osteomyelitis is common occurring في TB itself. الhips في spine اللي هي vertebral osteomyelitis. الpost disease اللي هو when you get vertebral osteomyelitis and it breaks into the back and produces an abscess. That combination of osteomyelitis plus an abscess, a paravertebral abscess, is called Potts disease. This is يعني ده كان اسم زمان كانوا يعني ممكن نعمل محاضرة كاملة على Potts disease, but nowadays actually you might actually see in your life 1 or 2 cases only. So very quickly about how do I diagnose TB. يعني هتشوفوا تقولوا well the clinical picture doesn't differ much from actually regular even infections itself. So that makes the history very important. history of exposure to somebody with TB is very important to elicit in those patients. Also, the circumstance, the epidemiology of the situation itself, where did he actually pick up the infections and so forth, and what kind of environment he's living. Those two things actually can make the diagnosis, and especially in children actually, because I'm going to tell why, how the other tools are very difficult to make sure that you're dealing with TB. So the history itself, clinic manifestations, there's not much really differences كبيرة. غير انه مثلا زي قلنا في الليمف نودز الاكيوت انفكشنز ممكن يكون الليمف نودز are red and hot and so forth and tender, while in TB they're actually non-tender itself. But that is not always in the case itself. So how do we know that? Actually, in addition to this, we do other things. One of them is PPD skin testing. Skin testing, but the only problem with skin testing tells you that you've been exposed to the TB bacillus. It just doesn't tell you this is an acute exposure or a chronic exposure. So that doesn't tell you. It's just that once in your lifetime you have been exposed to that. So that's why we sometimes look at the picture, the history, physical examination, and in the presence of a positive PPD skin and try to weigh and say, could this be TB or not? And a lot of times we suspect TB, but we never confirm it in children. The only way to confirm it is to do some of the other testing itself, and actually, it's actually doing biopsies, looking and trying to figure out actually to recover the bacillus itself. But other tests also can you use for screening. Viral skin testing is what actually we were just talking about. We have now a blood test which we call an interferon release assays, which actually measure interferon, which is released by lymphocytes that have been exposed to the mycobacterium antigen itself. So they release a specific type of spectrum of interferon, and you can detect it by blood test. And it's like almost like doing a skin testing, BPD skin testing, but through a blood test itself. But here, the confirmation is actually trying to recover the organism itself. You recover from the sputum, you recover from the pleural fluid, from the CSF, or something like that. You do for it microscopy. Oh, sorry. You can do it for microscopy, or you send it for culture. Or you can do on the organism itself what we call a PCR in order to detect the DNA itself. The problem in children, microscopy can be actually negative in 60 to 70% of cases itself, because as I said, the amount of bacilli can be very low. Even the CSF, sometimes you may not see the bacillus itself. بعكس others actually you can sputum حيكون full with bacilli, while in a child, most of the time we don't see it. Culture also in children, actually the culture can be only positive in about 40 to 50% of cases itself. The PCR itself can be positive only in 70 to 90% of cases. But there's always a margin of gray area in children that we cannot detect it. So it's much difficult in children to diagnose a case of TB itself. So this is, now these are some of the x-rays that you can do it, but they're sort of according to the condition, but they don't have any specific things that show, unless, مثلا زي في high lymph nodes, if you see in the x-ray with high lymphadenopathy, that suggests TB rather, because not a lot of diseases produce high lymph nodes itself. Like now, هو بس guys because the treatment is not much different from others, but I might want to focus something but for investigations اللي هو ال PPD skin testing. Just to remind you, actually, PPD skin testing is done on the skin, on the left forearm. And you don't read it actually immediately. You read it after 48 hours to 72 hours. And what you read is actually, you're looking for induration, not redness itself. And you measure the induration. Now, if your induration is, at least what I usually do is, if it's 10 millimeters or more, then we consider that as positive. Less than that, it is reactive, but it's not positive itself. Except in some situations معينة, you may consider as positive. Now, sometimes you may get a negative skin reaction itself. And we've seen that. As I told you, in patients, Somebody is allergic, immune deficiencies, you might get it negative. Malnourished children, you can get it negative itself. If you do it before 2 weeks, you're going to get it negative itself. If you have overwhelming infection, you can get it negative. So those are a lot of negative possibilities that actually, if you're on steroids or something like that, so it can be negative. Now, sometimes 5 to 10 millimeters is considered positive if you're dealing with HIV patients itself, and sometimes also some will add cancer patients itself. So HIV, those who are immune suppression, then you might use a smaller range. But generally speaking, most of the people will use 10 millimeters as positivity itself. I'll skip this. Now, treatment itself, just a few words about treatment itself. Very important, in addition to medications, is resting and good nutrition. That actually in the past, some people used to, in the past, when they didn't have any anti-TB medications, they put them in a sanatorium, or by then they just give them good feeding and actually fresh air and all that, and resting and all, and that used to be actually quite helpful actually. But I mean, better than nothing. But then we have medication. So it's important to look for the patients, good for the nutritional aspects of them, and we have to work on actually trying to make sure that the infection doesn't spread to other people itself. That just which are dealt with the public health issues itself, the contact tracing and so forth. Isolation if you're inside the hospital to prevent. During the active period in which you're actually treating, we put them in isolation because it can be airborne, it can be dangerous, can spread around to other people and to the doctors themselves. So there are certain isolation measures. You have to put them in negative pressure rooms. When you use masks, you have to use the N95 mask because and so forth. I mean, these are very important restrictions. And always the general principles, we never use one medication, we use multiple medications itself, usually around 3 to 4 at the very beginning, and then after 2 to 3 months, we scale it down to only 2 medications. Usually we use the INH and rifampin as our major backbone of our major medications that we use. These are some of the side effects. Yeah, and you should know something about the medications and some of the side effects itself. INH is one of the basic things, and major side effect of it is peripheral neuropathy itself. Now, all major 3 ones, INH, rifampin, and pyrazinamide, are hepatotoxic. So you should remember that, and that's why we have to monitor always LFTs when we're using these medications itself. INH, in addition to that, can cause peripheral neuropathy, and that's why we give vitamin B6 in order to prevent that from occurring itself. Rifampin, in addition to hepatotoxicity, can produce some side effects. It's a very potent liver inducer, so if you can give any other medication which is metabolized by the liver, metabolism can be enhanced by it. Few drugs, like chloramphenicol, can use to be enhanced. It's important to remember contraceptive pills, when you're using rifampin, rifampin can make the contraceptive pills ineffective, and that's important to remember. Actually, it stains the secretions, the eyes and the urine and all that, to red or orange. Therefore, you have to warn the patient about that, or else he's going to panic and think that he's bleeding or something like that. And also, you should warn him from not using contact lenses, especially in the eyes. Pyrazinamide is also hepatotoxic, and initially that can cause elevated uric acid, so it can give you gout-like symptoms. And ethambutol can produce optic neuritis. It's not hepatotoxic, but can cause optic neuritis, and that's why we tend not to use it a lot in children. I use it a lot, but we tend not to use it except in older children itself, because you cannot actually check. You should check your vision before actually you start treatment with ethambutol itself. Streptomycin, we don't use it nowadays a lot, except in meningitis, because it penetrates well in the CSF, So if you have meningitis, we might use streptomycin with it, or else we don't use it because it's from the same family like gentamicin and cause renal toxicities. And these are the other drugs itself. Maybe you can't, we don't use them a lot, but in others you may lead to. The last few words probably that most of these are can cause hepatotoxicity, so you need to monitor your liver function test. Duration, pulmonary disease, generally we treat them for about 6 to 9 months. And others I know we use shorter periods, but in children around 6 months, 6 to 9 months itself, while extrapulmonary TB, at least 1 year, if not more. If you have tuberculosis, then you monitor that and you try to make sure that they disappear على MRI before you stop the medication. So if you have other